Welcome to the video training series. I'm Lori Summers with the Iowa Cancer Registry. This presentation will cover navigating the Heme Lymph database. All of the changes for each year are listed on the website in the changelog. It's always a really good idea before you start abstracting a new year of cases to look over the changes made in the database. Several changes in histology have been incorporated in 2021 and 2022 based on the WHO classification of tumors for the heme and lymph tissues. This was the revised edition from 2017, and they do not revise the WHO books every year, but as they are finding more information, they implement all of the standard setter information from the ICD-0 3.2 update. Everything is effective for cases diagnosed since 2021 and later, and the changes are already in the heme database. So we can be assured that the most current information is available in the heme lymph database. One of the biggest things to remember is the heme lymph database is driven on year. So as you are searching and you actually select a disease, once you get into that disease, it will say, help me to code for diagnosis year. The default will always be the current year. So right now it would come up automatically 2023. So you are going to have to each time pull up the year that you are abstracting. So be sure to change the year. This option is available after you do have to search, you do have to select a disease, and then this option will show up. There are steps for using the heme database and the heme coding manual. The search function for the heme database has recently changed. Most of us won't really recognize or see a noticeable difference. On page 23 of the actual manual, there is a section on how to navigate and search the database. Use the helps that are in this manual, and it will definitely help you get more confident as you learn how to search. Each time you come to the manual, if you work through these same steps, you will get confident. The hard part with heme and lymph is you don't do those on a routine basis, and so you're not constantly in the heme lymph database searching on certain terms or looking in the manual for the multiple primary and histology list. And so it just takes a little bit of reminding on how to navigate them. So step 1, identify a working histology code. So when you open the heme lymph database, you will see the search field. You can search on a unique term as a text term from the path report. You could search on a histology code if you desire to do that. You could search on acronyms. So there's a lot of different ways to be successful in searching. One thing is if you have a unique word like precursor for a diagnosis of precursor acute lymphoblastic leukemia, I would search on precursor. Avoid searching on general terms like leukemia or lymphoma. This search will return way too many results. You can search on the complete name or diagnosis. The caution is the best way to do that is to put it in parentheses, like acute myelomonocytic leukemia. Otherwise, you will again get way too many options. You can also search on AMML for acute myelomonocytic leukemia. You could search on DLBCL for diffuse large B-cell lymphoma, or AML for acute myeloid leukemia. So there are hundreds of ways to search, and it really does just take a little bit of practice. If you have a path report or a flow cytometry that has a genetic string of acute leukemia with translocation or deletion, you could actually search on that genetic string, and that will also bring up a disease for you to look at to see if that matches the disease you have for a working histology code. So once you have a working histology, use the multiple primary rules to determine the number of primaries using the working histology code that you got by searching. You only use the multiple primary calculator when the rule tells you to use it. So you have your working histology. Now go to the M rules, starting with M1. Move through the rules in consecutive order and stop at the first rule that applies. The M rule references in the heme database at the top are used basically as a guide to get you in the right area. As you're going through the M rules, one of the rules will tell you use the multiple primary calculator. If the rule tells you to do that, then go back to that search page. That is where the multiple primary calculator is. So think about why you would be doing this. You are trying to decide how many abstracts, how many primaries you have. So the multiple primary rules in the heme lymph database are going to function in the same way that the solid tumor rules do that we've looked at, as far as trying to decide how many abstracts do you have. So if you have one tumor, one histology, you don't have to compare it to something in your database. You don't have complex histologies in the path report, then you don't need to go to the multiple primary rules. You already have your answer. It's just when you have a complex case with maybe a non-Hodgkin lymphoma or a Hodgkin lymphoma, composite or mixed tumors, that's where you need help with the multiple primary rules. Okay, so step 3 is verifying or revising the working histology that you got in step 1. Go through the primary site and histology rules, and remember that the search function gets you a working histology, but the histology is subject to change based on the multiple primary rules and the primary site and histology rules, the PH rules. So when the PH rules lead you to a different histology code, enter that code in the heme database search box and display the record for that histology. The PH rules referenced in the heme database towards the top are the most common rules used to code the primary site and histology for that selected histology that you are in. But on occasion, more than one module or PH rule may be needed to code the primary site and histology. So we would love for all of the solid tumor histologies and tumors to function the way the heme lymph database does, but it doesn't. And so you will see a lot more information in the heme and lymph database and manual, very specific to the heme diseases and the lymphoma diseases. And so it's a little bit more specific as far as telling you how to code the primary site and the histology. Okay, so the manual also helps you determine the primary site code to use. For certain histologies, only one primary site code is an option. If that's true, that will be given to you in the heme database, and that's the code that you will use. When there's no primary site given to you, when there is no primary site code listed under primary sites in the heme database, so this would be you've searched on a disease and you've gone into the database and you're viewing one histology. If there is no primary site code listed, you would review the primary site text field for common primary sites of what it might be. Search the heme manual or the database to find the applicable modules. And so the heme manual will tell you PS4, PS5. It will tell you which primary site and histology code to go to. You can also read the abstractor notes to find out other information regarding sites of involvement. So remember that, one more thought on primary site, back on the previous slide. Remember that just because you have a lot of disease doesn't mean you take all of that into consideration for heme and lymph diseases for the primary site. You are still going to have a primary site, and then your extension codes will reflect all of the places that disease is. Okay, so step 5 is determining the grade, and this is only for 2010 to 2017 cases. Starting with 2018 diagnosed cases, grade is no longer collected. So if you're working on an old case, the grade will be given to you in the heme database. And then there are grade rules as well, but you usually don't need those because the grade is given in the database when you're supposed to code that. Okay, so just to reiterate again, primary site. Per Jennifer Rule at SEER, not all sites of involvement are used to assign the primary site. Some sites of disease may be metastatic. In Module 7, so we are in the heme manual, Module 7, and it's the primary site and histology rules 18 to 27. It says, do not simply code the site of a biopsy. Use the information available from imaging to determine the correct primary site. This happens a lot with lymphomas. The PET scan might show a lot of disease. They pick one lymph node that is accessible and they do a biopsy of that lymph node, either taking it out or just doing a fine needle aspirate. And that gives them the disease that this person has. That is not the primary site where they did the biopsy. You have to look at the big picture, including the imaging, anything else that was done to determine the correct primary site. Note 3 explains that secondary involvement of distant lymph nodes for an extranodal lymphoma, which could be bone marrow, liver, spleen, or CNS, these secondary sites, are included in the stage fields only. This secondary involvement excludes rare primary lymphoid neoplasms of the spleen, multifocal lung involvement, liver, or CNS. Secondary involvement of distant sites is disregarded for the purpose of coding the primary site. For lymphoid neoplasms, this secondary or distant involvement is similar to METs for solid tumors. So if you think about doing a solid tumor, the METs really doesn't alter the primary site that you assign it to. So a similar concept here, even though you're taking into consideration all the disease that the patient has. So say you have a lymphoma and they biopsied a cervical lymph node. The primary site isn't cervical. It would be multiple lymph nodes if different other lymph node areas are positive or on imaging show that they are positive. Okay, so let's switch gears a little bit and look at reportability. This section starts around page 27. These are the reportability instructions for heme and lymph. So back again at the search function in the heme database, you can quickly pull up search on anything and it will tell you if it's reportable or not. Report all cases with the morphology code range listed here with an invasive behavior. We do not report in situ lymphomas. Report the case when the disease is preceded by an ambiguous term. So remember our reportability rules. You do have to report the case, even if it's ambiguous, but we'll see here down the road that we do not use histology described by ambiguous terms. So here are the ambiguous terms for reportability. Note 1. Use these terms when screening all reports other than cytology and tumor markers. Report cases that use only the words on the list or an equivalent word such as favored rather than favors. Do not substitute synonyms such as supposed or presumed for equal or comparable with. Do not substitute likely for most likely. In the SEER coding manual reportability section spells out that is our main source of telling you what is reportable or not. Accept the reportable term and report the case when one part of the medical record uses a reportable ambiguous term such as apparently, and another part of the record uses a term that is not on the reportable list. Do not report the case when the biopsy or the physician's statement confirms a non-reportable condition or proves the ambiguous diagnosis is wrong. There are separate rules for assigning histology with ambiguous terms. Do not use this list for histology. Do not report cases diagnosed only by ambiguous cytology. For example, an FNA of a parotid guided, ultrasound guided FNA consistent with non-Hodgkin lymphoma. This case was diagnosed based on a fine needle aspirate, which is cytology, and it's preceded by an ambiguous term. So this is not reportable unless further testing shows that it is. Do not report this case based on ambiguous cytology. Okay, so let's look at the multiple primary rules. There are general instructions for the heme and lymphoma manual multiple primary rules. They do function a little bit like the solid tumor rules, where you start with M1 for each case, move through the rules, and stop at the first rule that applies. Use the M rule references in the heme database as a guide only. Within these rules, the term chronic neoplasm means that a neoplasm has the potential to transform into another more acute neoplasm. And we'll talk about transformation too. It is a concept that is typically only for heme and lymph diseases. It's common to have a provisional diagnosis or several provisional or differential type NOS diagnoses that lead to more testing and a more specific diagnosis. Keep in mind that these are not multiple primaries. These are just steps in the diagnostic workup. And then again, the multiple primary rules will tell you when to use the multiple primary calculator. Otherwise, don't be tempted to use that because you will get the wrong answer. So this is what the multiple primary rules look like. There are numerous and multiple notes and examples for each of these rules. Be sure to read through the rule and read the notes to see if it fits what you have. Remember, when you get ready to use the multiple primary rules, you have already done a few steps in navigation and you have searched the database so that you have a working histology before going through the multiple primary rules. So in all of these, it would be a single primary. M1 when you don't have a lot of information. M2 when there's a single histology, it's a single primary. M3 when you have a single primary regarding a sarcoma diagnosis, simultaneously with or after leukemia of the same lineage. M4, you have a single primary when you have 2 or more types of NHL simultaneous in the same anatomic location. So that needs to be the same node, the same organ, the same tissue. And then M5, it's a single primary when you have both Hodgkin lymphoma and non-Hodgkin lymphoma simultaneous in the same anatomic location. The same node, the same organ, the same tissue. M6 is a multiple primary when Hodgkin lymphoma is in one location or one node, and non-Hodgkin lymphoma is in another location or a different node or tissue. M7 is a single primary when the more specific histology is diagnosed after an NOS, when the heme database multiple primary calculator confirms the NOS and the more specific are the same primary. So here's one of the rules that tells you to go back and use the multiple primary calculator. Okay, codes M8 through M13. These are rules that are comparing an acute and a chronic state of the disease based on the transformation rules and the definitions in the manual. So there's a section of definitions regarding transformation that is very good if you go back and read through that to just get some understanding of what they're talking about. The transformations of the acute and the chronic have to be listed in that disease for each other. So if a chronic transforms, it has to transform to that acute disease to make the rules fit. If a chronic transforms to a different acute than what is on the path report, then the transformation rules do not apply. So the diagnosis has to be a chronic or an acute of each other. And in the database, when you pull up a disease and scrolling clear down to the bottom, it will tell you this can transform from a disease, or this disease could transform to a different disease. So if you think of transformation as the histology is actually changing. This is very different than solid tumors where you've got a tumor and it metastasizes to an entirely different organ. If they sample that metastatic site, they can say, oh, well, this tumor was in the lung, but we can tell this is from the breast. In heme and lymph diseases, it does not function that way. If a chronic type of a disease or a disease state transforms to an acute, that tumor is actually changing. The histology is changing. The dynamics of that tumor is changing. So M8 is a single primary. Code the acute when you have both chronic and acute. diagnosed simultaneously or within 21 days, and you only have one biopsy. And in that one biopsy, you have both chronic and acute. M9, the single primary, is a single primary, and you code the later diagnosis when you have both chronic and acute diagnosed simultaneously at the same time or within 21 days, and there's no available documentation on the biopsy. So both of those scenarios would be single primaries. It starts to be a multiple primary. You're looking at timing rules here. The multiple primary in M10 when you have a neoplasm originally diagnosed as a chronic neoplasm, and the second diagnosis of the acute is greater than 21 days after the chronic. And then multiple M11 would be when you have both chronic and acute neoplasms. They're diagnosed simultaneously or within 21 days, and you have documentation of 2 biopsies, and it confirms that one of them is chronic and one of them is acute. And so it really is easier to look through these rules when you actually have these diseases in front of you. There are some treatment-related transformation rules. So both 12 and 13, it depends on if the patient was treated. So M12, single primary, when the neoplasm was originally diagnosed as an acute, and it reverts back to a related chronic neoplasm more than 21 days after the acute, and there's confirmation available that the patient was actually treated for the acute. So they could have, like, diffuse large B cell is considered in an acute state, and after treatment it could revert back to a follicular carcinoma. That would be the chronic. And that would be for M13, multiple primaries when the neoplasm was originally diagnosed as acute and reverts back to chronic after treatment. So there's a little bit more information you will need if you get to M12 or M13. Was the patient treated, or no confirmation that the patient got treated in M12? And then M13 would be they did have treatment. M14 talks about the post-transplant lymphoproliferative disorder, the PTLD, and if it's diagnosed simultaneously with another B cell or T cell lymphoma. I did include a couple of notes here. This is pretty rare, so you can see it's down on the list pretty far. There was a different rule for the cases up to 2020. If the PTLD is diagnosed after 12/31/2020 and is followed by a lymphoma, the lymphoma is actually the first primary. And then M15, if you get through all the rules, nothing seems to apply, it tells you to use the multiple primary calculator. At this point, before I do that, I would go back through the rules just to make sure that I haven't missed something with my working histology. Okay, so let's look at the primary site. The primary site code instructions begin around page 35. There are several notes. We'll cover this again. Do not simply code the site of a lymph node biopsy. Use the information available from the scans to determine the correct primary site. There's no hierarchy among the items on this list. For heme neoplasms, the path report is not always the default for determining the primary site, especially for lymphoma. The standard for determining primary site differs depending on the specific histology. If there's a heme neoplasm and it's diagnosed by a peripheral blood smear and you don't have any other information, then the rules will tell you you code that to bone marrow, C42.1. So there are some specific rules for coding the primary sites in the heme database. Do not use these primary sites for heme neoplasms, the 2A and B. If the heme database gives you the primary site, definitely use it. And number 4, remember, take a lot of information in together when you're coding the primary site. Look at the scans, look at the clinic, the medical documentation from the clinician, look at the path report, look at the heme database. Remember that secondary involvement of distant lymph nodes like an extranodal lymphoma, bone marrow, liver, spleen, CNS. Those are more for staging purposes. You still obviously collect that information, you text it as far as being thorough with all of the disease going on. But as far as primary site coding goes, all of this other disease will be reflected in staging. And then code the primary site as indicated on these pages for each category of disease. I'm really just highlighting a lot of these areas, but definitely go back to the heme manual, look through these areas. If you want, you can download this like a PDF and highlight some of these areas, but it's easy to just kind of forget how to navigate and what these areas are telling you because you just don't use it as often as the solid tumors. So here are the histology instructions. These rules cannot be used, obviously, for any other solid tumor. So for histology for heme and lymph, code the histology defined by the definitive diagnostic method, and that is listed in the disease on the database. There is no hierarchy to this list. So you can take the histology from anything listed there from A to E. When tester reports defined the definitive diagnostic method are not available, then you will use the documentation in the medical record, the scans, the genetic testing, immunophenotyping, flow cytometry, path report, or any documentation in the medical record that refers to the histology. When a tester report lists a specific histology with the ambiguous term and an NOS histology, code the NOS histology. Remember, the ambiguous terms are used for reportability. The ambiguous terms may not be used when specific histology has not been confirmed. If there's no further information regarding the more specific histology, assign the NOS. And there are many notes and many examples all throughout this whole manual and database, and they are very helpful. So do take time to read through those. If there's only one histology preceded by an ambiguous term, review the notes, look at the heme database, look for other information to confirm the diagnosis. Obviously, you don't want to miss reporting the incidence of cancer, and if that's all you have to report it. So I think this example was given, the CBC shows lymphocytosis. You don't have any histology or provisional diagnosis on the CBC or the peripheral blood smear. The flow cytometry states compatible with CLL. There's no other workup done. Per the abstractor notes in the database, the abnormal lymphocytosis is present in CLL, so you would assign the histology to the 9823/3 CLL, since abnormal lymphocytosis is part of the CLL SLL definition. And so what they're talking about, if you search on CLL, go into the database, pick your year of what your diagnosis is, and read the abstractor notes in that disease, then you will see that this is a CLL. Compatible with CLL is a ambiguous term, but if that's all you've got, you have to use it. If a relevant immunophenotyping or genetics is present in the abstractor notes and the only histology preceded by an ambiguous term is what you have, code that ambiguous term for incidence reporting. Don't not report it just because it's preceded by an ambiguous term. Okay, so now let's look at these are called PH rules. They're primary site and histology rules. There's 9 modules. Each module covers a group of related heme or lymph neoplasms. One neoplasm might be in more than one module. These modules are not hierarchical. You kind of can shop around in these. The rules within each module are in order. So once you get into a module, you have to apply the rule in order of the module and stop at the first rule that applies. So here's what I'm talking about with the modules. Module 1 covers the PTLD. Module 2 covers the plasmacytomas. Module 4 is a very common one with leukemia and lymphoma. And each of these modules at the top list out all of the histologies. So that is a really good place as a double check. Take your working histology and find the right module. Once you're in a module, then walk through that in order and stop at the rule that applies. If you get through those rules and it doesn't apply, it will probably send you to a different module. Module 8 is the NOS and the more specific histologies. So if you start in module 6 and it doesn't apply, you might end up in a different module. So let's look at, I'm in module 7 and I'm at rule PH 18. And this module 7 covers Hodgkin lymphoma and non-Hodgkin lymphoma. So this is applicable for both Hodgkin and NHL. Code the primary site to the specified lymph node region when the site of lymphoma is described only as a mass. So what they're talking about is if you have a mediastinal mass and it's biopsied, code mediastinal lymph node C771 when the site of the lymphoma is described only as mediastinal mass, and that rule can follow down here with these other lymph node regions. If you have an intra-abdominal mass, if you have an inguinal mass, if you have a pelvic mass, these are translated into these primary site codes. Okay, now let's look in module 3 for the CLL SLL. This will direct the primary site coding to either bone marrow or lymph nodes depending on the findings. So it tells you what to look for in the record. PH5, primary site histology rule 5, applies to coding the primary site to the bone marrow when the bone marrow is involved or when the peripheral blood is involved. So if you have a bone marrow path report and it is CLL, SLL, the primary site will be coded to bone marrow. Now look at pH6. Code the primary site to the involved lymph nodes or that lymph node region or the organ or the tissue when there is no peripheral blood involvement and no bone marrow involvement, or you don't know if the bone marrow is involved. And so CLL, SLL could be coded to the bone marrow, or it could be coded to the primary site of lymph nodes. And it just depends on where the disease is. There are appendices towards the back of the manual. It's easy to forget they're back there. Appendix A is more of a history lesson on heme and lymph. Appendix B shows the histology lineages and displays tables for different lineages. And that can come in handy when you're looking for an actual code. Appendix C is for identifying which chains of lymph nodes are in each region. Use this table with the primary site and histology rules to determine whether involved lymph nodes are in a single ICDO lymph node region or if you have multiple lymph node regions involved. This table in Appendix C contains the names of lymph nodes that have capsule and sinus structures of true lymph nodes. So you are not going to find lymphoid tissue like GI tract, tonsils. Appendix C only has lymph node chains. And then Appendix D is fairly new, and it's mostly just for information to explain the genetic nomenclature. So here's what Table B6 looks like. In Appendix B, the histology lineage was updated when all of the histology terms were updated in the WHO Blue Book. Use the heme database to identify synonyms that correspond to these terms. The stars in the right column are new histologies that were updated with the 4th edition of the WHO Blue Books. And I see using Appendix B for the WHO preferred term and grabbing a code that you can take to the database. So Appendix B is updated with all of the new codes and behaviors as mentioned earlier, and it can help you narrow down the genetic abnormality searches on the database. So if you have your path report and you come to Appendix B, it's almost easier to see what the options are here. You're not directly searching in the database blindly to pull up one of these. And so it might be a little bit easier to look here first to find what your comparison is from what you've got in your path report. Grab that code in the last column and then go search in the database. And then just looking at this genetic nomenclature document, it is 4 pages. This table is around page 83, but it might be helpful just to understand the deletions, duplications, translocations, the trisomy and the monosomy, and understanding if these are abnormal or mutations. SEER Educate has provided information in Appendix D here for the purpose of brief introduction, looking at the nomenclature, some of the genetic alterations, and the molecular information needed to successfully code heme diseases. So this is not all-inclusive. Some of the terminology you might encounter, but it really is intended to just introduce the subject matter as a whole as a reference. Okay, so to wrap up, let's reorient ourselves in the heme database, practice searching different ways. You'll eventually find exactly what you're looking for. A search can be done if you have a code from Appendix B, start with that. Otherwise, try to search on the unique term or terms. You could search on the genetic string. You could search on the acronym. And so those first, under the search here on the slide, you could search on any of those, RAEB or that genetic string. Looking at the alternate names can also be a clue to realizing that you do not have to have the entire genetic string listed to be that disease. For the 9897.3, the AML, the path report may only show the 11q23, but you don't need that entire string for it to be that disease. So 11q23 is enough to code 9897, even if you don't have the P22 and the Q23. In the genetics data or the immunophenotyping section, the terms expression and positivity mean the same thing. Remember that the list of genetics or immunophenotyping testing can be done in a variety of ways, like FISH, flow cytometry. All of the listings in the database may not be complete, but if you are having results from a test that is giving you a more specific histology, then you definitely want to use that immunophenotype or testing that was done. This means that the genetic data would be positive, that would allow you to code the more specific histology. All right, I know that's a lot of information. Do go back to the manual and the steps for navigating, and that's where I start every single time, just so I don't forget some of the steps of getting a working histology, going through the rules, and doing that in order will ensure that you're not skipping any steps. If you have any questions, you can email me, and thanks for listening.